Welcome to our second episode in this 8-part case series on advancing the standard of care with cellular and tissue-based products. This series is brought to you by Smith & Nephew. I'm your host, Dr. Harry Schneider, Assistant Professor of Surgery at Harvard Medical School and Residency Director at Cambridge Health Alliance Department of Podiatry. In this episode, Dr. Jason Anderson, physician and surgeon at Jayhawk Foot and Ankle, Kansas City, will be presenting a case on the use of placental and umbilical tissue in wound care.
Good day, everyone. I will be presenting a case study on foot abscess in amputations. This gentleman is a 35-year-old, relatively young, morbidly obese diabetic. He's a native gentleman who came to me from quite some distance, and he presented initially with a necrotic abscess beneath the fifth metatarsal. One of my least favorite wounds to see is sub-fifth metatarsal ulcerations. Just inevitably, unless aggressively managed, they're going to wind up on your doorstep with something looking like this, in my experience. And this guy was coming from 3 or 4 hours away every time with, I think, taking some form of either bus transportation or a buddy of his would bring him. So it adds to the dynamic of these cases where you may have to get more aggressive in some shape or form, and it goes into the point of trying to get these wounds closed as fast as possible in these complicated scenarios. So again, the top left picture is what you see when he presented to me. We ended up doing an amputation of the fifth toe. You can see that's non-viable. He had an abscess extending over the majority of the dorsum of the foot, and initial debridement, we took the fifth toe off, applied a STRAVIX, which is really a game changer in some of these complicated gangrenous feet. It manages soft tissues really effectively, and I've had really good success in these scenarios. I then applied a wound vac. I generally start at 100, maybe sometimes 75, depending on the surrounding tissues, for 5 days over top of this graft. And you can see that on the bottom left picture here, where that's the first removal of the vac. And you can see the non-adherent layer on top yet. Again, I leave that vac on for about 5 days. After that, I'll pull the non-adherent off, and I'll start increasing the vac pressure. Twice weekly changes at 125, sometimes more frequently. Again, the distance and the logistics played a little bit of a role here. Patient ended up going back to the OR and ultimately getting the split thickness skin graft application. We did end up taking the fourth toe, maybe could have salvaged that, but kind of got to choose your battles, especially in this scenario. But you can see in the middle bottom picture, you have this sort of fibrous, granular mixed wound bed. It's perfectly normal at that stage to develop sometimes more of almost a necrotic looking graft, but you just have to trust the process. Between that second and fourth week, that graft will look almost scary, black and kind of fibrotic. It's not the time to debride that graft out. It's not infected. And actually, I'll sometimes take an 18-gauge needle and puncture that graft a few times to maybe there's a little hematoma underneath there, but usually not. But it helps incorporate that graft even quicker in my experience. You can see then on the far right, about 8 weeks into this or less, he starts developing 100% granulation tissue. And again, expediting the closure, I decided to put a split thickness skin graft. I was able to close the fourth toe amputation site in a primary fashion. This went on to heal perfectly with a complete incorporation of the split thickness skin graft. On the split thickness skin graft, I will oftentimes apply a graphics, and I've found that to help incorporate that graft even more efficiently, especially in these complicated cases. We ultimately were able to close this wound and salvage the limb with a functional limb in 3 months. This has been a presentation on amputation management with the use of graphics and STRAVIX. I appreciate you watching. Thank you.